Hello and welcome everybody to our special COVID-19 session number 24. This is the 24th session of our series of COVID-19 related diagnostic sessions that we have dedicated to diagnosis in the laboratory for SARS-CoV-2. Today we have an interesting subject where we are going to be giving findings from our colleagues from FIND in which they tried to independently evaluate diagnostics for SARS-CoV-2, particularly antigen detection immunoassays. As you know, we have seen this is probably one of the ways that we are going towards as we are trying to fight the pandemic. Just also for record, we saw the first antigen detection test being listed on the WHO EUL, I think just about a few days ago, 22 September to be specific. So to do that, today we have lined up Dr. Gillian Sachs from FIND, who is currently the head of pandemic preparedness. As well as Owen Dimke from CHAI, who are going to take us through this subject. Firstly, in how these tests have been performing and what are the other key characteristics that we may need to look at in order to choose these tests and actually ultimately efficiently implement them in our systems. So we will have this session to be a 1 hour long session, made up of the two presentations, followed by a question and answer. Please hold on to your questions or keep them coming through into the chat box. We shall attend to them immediately after the two presentations have elapsed. Allow me to call upon our first presenter, Dr. Gillian Sachs from FIND, to take us through the first presentation. Over to you, Gillian.
Great, thank you, Anafi, and thank you to ASLM for the invitation to present today. So I'll be giving an update on FIND's evaluations of SARS-CoV-2 antigen detection immunoassays. So as everyone is already aware, access to timely diagnosis for COVID-19 is still quite a challenge. But in the absence of a vaccine or a specific treatment, control of the pandemic is mostly dependent on rapid identification of individuals who are infected, followed by tracing, isolation, and clinical support as needed. Obviously, the current gold standard is nucleic acid testing, which relies on access to centralized laboratories or more decentralized ones. But in general, turnaround times can vary from more than 1 day to more than 1 week. So an alternative approach to diagnose current infection with SARS-CoV-2 is to test for viral antigens or proteins that are shed by the virus during replication, and which are most detectable within the first 7 days or so post-infection. So in this cartoon, I've just highlighted in the red box the timing when we expect antigen to be most detectable. And this is overlaid with detection of nucleic acid by PCR in various sample types, as well as the detection of antibodies. So a little bit of background on what antigen detection assays are. So many of tests are now becoming available, which are immunoassays. Some of them are in a lateral flow test format, also called rapid diagnostic tests. And they target the viral antigen, mostly the nucleic acid protein highlighted in this cartoon. The antigen RDTs currently require the use of an upper respiratory swab, mostly the nasopharyngeal swab, and results can generally be available within 30 minutes. And I've just shown a cassette type rapid test here on the right-hand side. There are some tests that may be compatible with nasal swabs, but there's more data needed for that. So to date, as Anafi mentioned, There's one test that has now been listed through the WHO emergency use listing procedure. It's the SD Biosensor Standard Q assay. This is a lateral flow test that can be read visually. The United States FDA has also, through its emergency use authorization procedure, approved 4 different antigen detection assays, some of which require an instrument, one of which is just a lateral flow visual test from Abbott called the Binax. And then you can also see that Japan and Australia have also approved some assays, which are visually read, as well as the final Fujibio Lumipulse, which is an ELISA-based assay. And all this is to say that there is becoming more and more data on these assays. So as you heard in the previous webinar, WHO is continuously updating their guidance on testing for SARS-CoV-2. And I'll just reiterate that nucleic acid testing is still the preferred test where possible, but that antigen detection assays can be used if their performance is acceptable. And the expectation is that higher viral loads will be associated with the improved performance of antigen tests. I'll also just reiterate that WHO at this time does not recommend the use of lateral flow assays that detect antibodies, but more studies are needed, and perhaps we can present data on our evaluations of antibody tests at a later time point. So I'll just reiterate what the minimum performance requirements are that WHO has suggested, which is 80%, at least 80% sensitive and 97% specific compared to nucleic acid testing. And then there is some recommendation that the antigen RDTs should be conducted by trained operators according to the IFU, and preferably within the first 5 to 7 days following symptom onset. So how well do commercially available products actually align with these WHO recommendations? So FIND actually set out to do limited performance evaluations of both molecular tests and immunoassays to support their rollout in lower resource settings. And we started this back in March. So at the end of March, for the immunoassays in particular, we launched expressions of interest for suppliers to submit their tests for us to consider evaluation. At the time that we started this work, there was no emergency use authorization or emergency use listing procedures. There was no gold standard reference assay, and there still has yet to be a reference standard. So all of our results are in comparison in relation to PCR. The way we selected the tests is suppliers submitted forms as well as their instructions for use. And we evaluated and assessed the tests based on their regulatory status and time to market, their manufacturing and distribution capacity, particularly in low and middle income countries, as well as the supplier reported clinical and analytical performance. And I will note that we continue to select more tests as they become available for evaluation. So the way we've designed these studies is they're prospective diagnostic evaluation studies. We're working with multiple independent sites who are consecutively enrolling individuals. And each individual then gets 2 nasopharyngeal swabs. One is for routine PCR testing, and the second is for the antigen RDT under evaluation. The data that I'll be presenting today was generated across 3 countries, depending on the test, in Germany, the United Kingdom, as well as in Brazil. And there were different recruitment sites where the tests were performed. We also have additional studies that are starting in Peru, India, and South Africa, as well as Nigeria, later this month or next month. The inclusion criteria generally were individuals in the community who meet their national suspect case definitions at the time. And obviously this varies. And none of these patients, for the most part, were severe enough to be hospitalized. They were able to ambulate and go to the clinic directly themselves for testing. In addition to the clinical analysis, we also performed a verification of limit of detection using dilutions of viral culture. And then we had an ease of use questionnaire that different operators completed to rank the tests in terms of their feasibility and suitability. So this is just a list which you can find on our webpage of the tests that we're currently evaluating and the status of those evaluations. So today I'll be presenting data for Chorus Bioconcepts RespiStrip test, the standard Q assay that I mentioned earlier from SC Biosensor, as well as the NowCheck assay from BioNote. So to start, the first assay is the RespiStrip. This is a strip test that you place, it's a piece of paper that you place inside of a tube. You add the sample as well as a buffer, and then the liquid migrates up the strip. And then you interpret the test as either positive or negative. These are just the specifications of the specific test that we evaluated, as well as the storage conditions. So this test we started evaluating in Europe, in Germany, and the UK. At the time that we were doing these evaluations, the positivity rate was quite low in these countries. You can see we only got 2% positivity, but we evaluated over 400 participants, and we found that the specificity was poor, so only 96% specific. And so because of that, we stopped the evaluation early. In addition, the end users found that the test was not easy to use, so the test scored less than 50 out of 100. And so we, in discussion with the supplier about these results, we're aware that they may be creating more training materials and they may be altering their test performance moving forward. So I know that there are many countries that may already be evaluating that test, and certainly we'd be curious to hear how it performs in the future. So the next test that we evaluated was the standard Q from SC Biosensor. This is a cassette-based rapid diagnostic test. In the kit, all of the required materials, including the swab that you need to collect the sample, are available. So this test we evaluated both in Germany, which is sort of a lower positivity setting, as well as in Brazil, and I can see there was a typo here, but where they had much higher positivity of about 26%. So in both countries, again, the inclusion criteria for the individuals where we did the testing was that they had to meet their local definition of being suspected to have COVID. They had to provide informed consent. As you can see, the majority of individuals in both settings had symptoms present at the time of testing. And then you can see that in Germany, the sensitivity was close to 80%, and in Brazil, it was close to 90%. We then broke out the sensitivity analysis in different subsets. So first we looked at sensitivity when you test someone who reports that they've experienced symptoms for less than or equal to 7 days. And you can see that in both settings, the performance slightly improves in this context. And then we also did the sensitivity according to cycle threshold value for the PCR comparator. So if we look at individuals who had a CT value of 33 or less, the performance goes up to close to 90% or over 90% in both settings. And if you restrict to analysis for individuals who have quite a high viral load, so CT values of less than or equal to 25, the performance improves even further. And this is in the context of good specificity as well, so 99% in Germany and 98% in Brazil. Very low to basically no invalid tests. And consistent with this, end users found this test quite easy to perform, so 86 out of 100. We also verified the analytical performance of this test, and we found it to be about 10-fold higher than what was reported by the supplier. But I will caveat this, that we used a strain that was isolated in the UK, whereas the supplier used a strain that was isolated in Korea, and perhaps there could be some variability. So the final test that we evaluated was the NowCheck assay from BioNote. Again, it's a cassette-based assay that requires a nasopharyngeal swab sample. Here I've just copied a little bit of the cartoon from the instructions for use so you can get the sense of what the workflow is, and this is very similar for many other of the rapid tests in that you collect a sample, then you insert it into a provided tube that has the proprietary buffer, kind of mix it around, and then try to squeeze the sides of the tube to expunge as much of the viral material off of the swab into the buffer. Then you put a little cap on the buffer and drop a prescribed amount onto the sample well of the cassette. And then after 15 or 30 minutes, you then interpret. So again, this test is also stable up until 30 degrees Celsius. So we evaluated this test in Brazil, again, with a very high positivity rate, 26%. So in this case, every single person who was screened during this study reported the presence of at least one symptom at the time of testing. We found that the clinical sensitivity was 90% or 89%. And then when we do those subset analyses, you can see that performance improves a bit when you narrow down the cohort into those who are likeliest to have the highest viral load. Specificity was also good at close to 98%. There was no invalid test, and we're still analyzing the data for the analytical performance as well as the ease of use. And I should note that all of these data are posted publicly on our webpage so that you can use them and inform yourself, and there's a few more details in the study reports. The final test that I'll mention is a test that's also becoming rapidly available and is also undergoing emergency use listing procedure review right now by the WHO. And this is the PanBio assay from Abbott. This test has a manufacturer claim performance of 91% sensitivity and 99%, close to 100% specificity. We're in the process of doing our own independent evaluation, so stay tuned. And again, storage is up to 30 degrees and with a nasopharyngeal swab. So I'll just start wrapping up by highlighting a few key messages. So firstly, unlike PCR, these antigen detection RDTs, for the most part, cannot rely on amplification of the virus. So it's expected that they will have some lower sensitivity than molecular tests. But we do have data, and I'm just showing some work here from Van Kampen et al., which shows on the left panel, the duration of symptoms versus the probability of virus culture. And in the right panel, the viral copies per mil compared to the probability of viral culture. And what you can appreciate is that earlier in the disease course and then with higher viral load, if you look at probability of viral culture as a proxy for the likelihood that someone is going to transmit to someone else, you can see that it's pretty clear that with higher viral load and earlier time in the course of disease, that likelihood is much higher. And so one can perhaps surmise that if you can detect individuals at this earlier time in their symptomology, when they have higher viral load, that perhaps the antigen test, even with their comparatively lower sensitivity, if they can capture these key high transmitting individuals, then perhaps they are sufficient and can have a real impact when it comes to overall management of the COVID-19 response. And our data show that some tests do have high sensitivity, so at least 80%, in the individuals who have CT values equal to or less than 33. And those are the individuals who are likely to be the most infectious. I'll also just highlight that with these antigen RDTs, which we are seeing perform well, there are some key recommendations to support their rollout from the WHO, and perhaps Owen will touch on these as well in his presentation. But There is a suggestion to try to consider implementing these tests in settings where NAT is available so that you can start to confirm their performance and allow staff to gain confidence that they are issuing accurate results when they use these antigen RDTs. If NAT confirmation is not feasible, obviously triangulation with clinical symptoms is needed. So if you have someone who you highly suspect to have COVID, they have an antigen negative test, you may want to collect a new sample and send it for confirmation, and vice versa. If you suspect a false positive, you may want to confirm that as well. And then something important to note is that antigen RDTs currently are not recommended in low prevalence settings until the specificity of the test reaches greater than 99% because of concern of high false positives in these settings where the pretest probability is quite low. So just to wrap up, I think some key messages are that there is likely to be substantial variability in the performance across different antigen RDT brands. And so having external independent evaluations of their performance as well as limited in-country validations of individual products is critical. From the data that I showed you today, we see that the standard Q and the now check do meet currently recommended sensitivity and specificity targets. And as I noted, that given the rapid result availability as well as ease of use, these antigen RDTs are likely to offer the potential for early diagnosis and interruption of chains of transmission in a way that current nucleic acid testing only systems are not able to. As I alluded to in the beginning, I think the determination of the accuracy of these tests with easier to collect sample types such as nasal swabs as opposed to nasopharyngeal may facilitate their uptake, and some of those equivalency studies probably will get underway pretty soon. As well as some key operational research on the impact of antigen RDTs for epidemic control and clinical management are also needed. So with that, I'll thank you for your attention and hand it over to Anafi to introduce Owen. Thank you.
Thank you very much, Gillian, for the wonderful presentation and sharing all that information. So next, please keep the questions coming and we will attend to them as soon as we finish the second presentation, which is going to touch on, after having learned all this, what are the other practical selection and implementation considerations that we can look at? And to do this, we ask Owen Demke from CHAI to try and take us through the presentation, then we get to question and answer. Owen, over to you.
Great, thank you. Could you let me know, is this coming through okay?
Yeah, it's coming through quite well.
All right, great. Thank you, Anafi, for inviting us here to speak today, and thanks, Jillian, for the presentation. So following on Jillian's presentation on performance evaluations, we wanted to take some time to focus on additional product considerations for the selection of products and also the subsequent impact on implementation. And as previously discussed by Jenny a few weeks back, high testing yields and low testing volumes have shown that there's room to significantly increase testing to stem the epidemic. Up till now, PCR has really been the gold standard for testing, but PCR has a number of limitations, and many of these can be addressed by antigen tests. A lot of this information I know has been discussed before, but I want to focus in on just four main considerations, and those include supply availability, cost, coverage, and turnaround time. For supply, I think we've all seen limited supply for PCR tests, particularly automated tests, and with large manufacturing capacity coming available for antigen tests, particularly RDTs, these can better meet the testing demand across countries. For cost related, current PCR costs range anywhere from 10 to 20 US dollars each, whereas antigen tests are now coming into the market around $5 or even less. And at these types of prices, This would allow an increase in testing volumes anywhere from 3 to 4 times that of PCR within the same available budget. Around coverage, PCR has typically been confined to urban settings and settings with strong sample transport systems. However, there remains significant gaps outside of these settings, and POC antigen tests can be decentralized both to lower level health facilities, more remote regions, and other areas that have not had sufficient access to PCR. And finally, just around turnaround time, the WHO has indicated rapid turnaround time is really critical for stemming epidemic. And in review of 10 different high volume African countries, turnaround times have ranged anywhere from 2 to 5 days, if not longer in some settings. And antigen tests really provide the opportunity to provide a result in just 10 to 20 minutes. And so really focusing in on some of these characteristics, I know it's been discussed in the past, but these are some really key areas and rationale for why antigen can be introduced in these settings. And with the operational clinical benefits outlined previously, WHO has now released guidance, which we've all seen. Jillian and Laura both discussed this in detail, but just wanting to come back to it and know that these guidance really form the basis for implementation planning and the subsequent slides that we'll talk about today. So as the benefits for antigen tests are clear and their use is now recommended by WHO, the focus can shift towards appropriate preparation and subsequent test introduction. So this slide here just portrays a framework of some of the key components for introducing and scaling antigen tests. It's important to note that work is really required both before, during, and after product introduction, and it's really helpful to start preparation as soon as possible. One of the key preparation components is appropriate product selection, and as highlighted here, it'll be the focus of this presentation. While there are just a few products currently available, and Jillian touched on some of these, and there's broader landscaping exercises that have been done to show the really large pipeline of tests coming available, it's clear that having an objective framework is going to be useful to best identify the products that meet individual program needs. We've seen it for manual PCR tests, and even with the antibody assays, as tests came available, they really flooded into countries through different channels, and being able to have a way to objectively look at the different characteristics really is going to be important. So with that in mind, WHO has developed an objective product selection tool that can assist in the prioritization of technologies. This tool was spearheaded by WHO with inputs across a number of different agencies within the diagnostics consortium, including Global Fund, CHI, FIND, Unitaid, and a variety of others have provided inputs into the structuring of this. The tool itself is structured similarly to another product prioritization tool that was finalized in the preceding weeks. This is a manual RT-PCR product tool, really looking at a number of criteria and considerations across those different products. So looking at the different criteria that can be focused in and used to inform product selection, these include not only technical performance, as Jillian had walked through, but also operational and supply related features of different tests becoming available. As many products begin to enter the market, the most critical components include meeting certain regulatory standards and minimum acceptable clinical performance. And beyond these, there are 7 priority features that are scored in the tool. These specifically include, and are listed here on the left, performance, price, company experience, capacity and supply, operational and programmatic features, sample collection, test format, so either RDT or instrument-based products, and finally, quality control. And as you can see here, they're ranked in order of a suggested priority, with performance and price really coming out in the front for product selection, and a variety of the other operational characteristics that come in as very important steps, but slightly lower priority than having, you know, that critical high performance test and affordable tests that can be implemented at scale. So focusing in here then on that first priority feature is around performance. I won't spend too much time on this. Obviously, Jillian provided a lot of in-depth analysis of some of the products coming available. But I first just want to stress that there will be a lot of products with variable data that are coming available. And so products with WHO EUL or other high quality data should really be prioritized. And the work that FIND is doing to put together some of those independent evaluations and the WHO EUL review of supplier data allows for that more rigorous analysis of supplier data and allows more of an apple to apple comparison across products. Now, from the sensitivity standpoint, WHO is indicated minimum thresholds for performance around that 80% sensitivity, but it's important to note that higher sensitivity is quite valuable really for minimizing false negatives, particularly in those high prevalence settings. And those might include settings like inpatient wards, contacts, healthcare workers, et cetera. And by contrast, for specificity, again, 97% specificity has been indicated as a threshold. However, in low prevalence settings, really high specificity tests, greater than 99%, as WHO mentioned, really should be prioritized so you don't have a high number of false positives that are in your testing population. Shifting forward to price, the tool considers a number of characteristics around cost. And I think the key point here is that an all-inclusive cost of the assay should be factored in when comparing the different technologies and doing budgeting. In particular, suppliers should really include all consumables required to obtain the result. As you can see here on the right, some of the key features include the test strip and buffers, the sample collection kit, and then any quality control reagents. So there are other features that may also be bundled in, including data management solutions or inclusion of device and device placement if that's required for the test. But you know, some of these pieces here really are key priority so that you can have an objective price and a transparent price, as well as allowing for rapid decentralization of the test kit, and it really simplifies procurement practices to have all of those required reagents in one procured kit. For Incoterm, just for those not super familiar with Incoterms, this describes kind of the procurement processes for a procurement of a test, and in particular, shifting to more inclusive Incoterms is more a simplification of procurement processes and allows for price transparency. So as you shift towards a more inclusive term, and I've listed a couple here, but that shift really puts responsibility onto the supplier for shipping of the tests, and potentially clearing through customs, as well as managing all the procurement related costs. And we've seen in a number of countries, this can range anywhere from 10% to 20% or more for just the procurement related costs, which obviously comes back into your overall budgeting and being able to utilize the funding available in the most in the best way. So finally, these come together within this selection tool as an overall cost per test that really captures the full test kit and allows for a direct comparison of different final product costs. So you can see here at the bottom, really a consolidation of all of the previous inputs. All right. So shifting forward, I think this is kind of the last key section around the product characteristics. And there's a number of additional priority features that should be considered or could be considered to select products. Since there's a lot on this slide, on the left are all the different features of products that are available, and on the right are the considerations for each feature that may help to best distinguish amongst technologies. Regarding company experience, as many new companies without any history of manufacturing or experience in the LMIC, in LMICs are starting to manufacture and supply these RDTs. Suppliers with existing experience or existing distribution networks may be preferred. In addition, focus should be placed on products that have a committed or secure supply for LMICs. And just on this point, discussions are ongoing with a number of suppliers across different groups to help ensure that this supply security is maintained. Shifting down then into operational and programmatic considerations, there's a variety of features here, but really the key things that stand out are a priority to be placed on products with simplified workflows. Jillian put forward some of the schematics of different tests that are now on the market, but really looking at how complex those workflows are and some of the ease of use indicators, because you're going to be decentralizing these tests to a significant number of sites that may not have the same monitoring and supervision that is available at centralized labs that have been doing some of the PCR testing up to date. Additionally, a focus on some of the other characteristics, such as more durable products, particularly in areas with extreme temperature excursions, and finally solutions that are available for data management. Jillian also mentioned a bit about sample collection, but really there's a shift towards, and you're seeing some of the suppliers come out with nasopharyngeal products, but also a few that have done evaluations of nasal swabs. And really, Karen Heichman presented on this a few weeks back about some of the benefits of a nasal swab, and it really does allow for ease of decentralization of testing, which is a key component of introducing antigen tests in the first place. And there's also a potential for even allowing self-sampling, which could reduce risk to healthcare workers, minimize PPE requirements, et cetera. The last two pieces, which I'll just mention briefly, are around the technology format. So they come in RDTs by themselves, devices that are required to read the result on the RDT through fluorescence-based assays, and finally POC devices that are actually required to run the test itself. Now, the requirement for devices obviously may lead to additional costs and service and maintenance, as we've seen with deployment of other POC technologies. However, this may come in a balance with potential performance improvements or simplified data connectivity solutions. So these things can be weighed based on the available information that's coming out, and these considerations are built into the tool accordingly. Finally, I mentioned this briefly, so I'll just touch on it shortly, that quality control, the tests on the market are in three different capacities. Either no control swabs are included at all. Some allow these quality control reagents are available from suppliers for separate purchase. And finally, some can be actually included within the box and are proactively included within the box. How important this is for individual context will obviously depend on the QA and QC programs that you have in place. And so it's a consideration, but maybe ranked a little bit lower in terms of overall weighting and priority. So how does this come together into what the prioritization tool itself is meant to do, and how might this be helpful or just even following a similar methodology as you consider the product selection within your country contexts? Within the tool itself, it's essentially a three-part process. So first, each technology should meet the minimum criteria that we discussed initially, and those are really those regulatory and performance thresholds for just a product being acceptable to implement in the setting. Secondly, individual criteria represent each of the priority features are then scored as not preferred, acceptable, and ideal. And for example, for workflow, as you can see here, 4 or more complex steps would be non-preferred, while an ideal workflow might be just a minimum number of simplified steps for implementing the assay. And obviously, this is directly correlated with ease of use. And you can see how these different considerations all add up into that overall operational and programmatic overall section. So finally, and leading into that, the criteria within each of these features are then consolidated and each section weighted by priority. And I've included some tentative weightings here, but obviously based on priorities and country, these can be adjusted and so that the tool can best fit with what the individual needs are. And finally, the output itself provides then a ranked list of suppliers based on all of these different input prioritization criteria. And so a lot of the landscaping being done to collect available data across all of the individual suppliers is helpful to kind of lead into and be the guts that are running this tool and providing the outputs needed. So the last point I just want to stress is that prioritization of these different factors can be adjusted based on country context. So such as countries with high temperature excursions and may rank storage conditions higher than other criteria within that operational or programmatic setting. All right, so I guess the final takeaways then, I'll just briefly run through, are that from the performance standpoint, really for low prevalence settings, tests with high specificity should be prioritized, and conversely in high prevalence settings, higher sensitivity tests should be likewise prioritized. And following on that, for price, the cost of the full test should be considered, and this includes swabs, controls, Incoterms, and also a variety of other price-related considerations. For operational considerations, I can kind of jump through this quickly, but really nasal collection and data management solutions may be quite important, but also having suppliers with experience supporting RDTs are quite critical. And finally, this comes back to an objective product selection process. So there need to be, and will soon be, a lot of products available with a significant number of characteristics. The tool that's been put together allows for an objective selection of these technologies and could be used. But just overall, a product selection process for each individual country should consider the technologies that best fit the varying needs. And a tool like this or some other process really would be critical to help identify what products are best for your setting. Yeah. One last point is just the selection tool is going to be made available shortly through WHO regions, and but overall, whether it's through this tool or another process, just that objective prioritization is really going to be critical for that product selection. So with that, I will stop and hand it back over to you, Anafi.
Thanks a lot, Owen, for the great presentation. Indeed, those key criteria will be important for selecting these tests. They mentioned the performance, the price, sample collection issues, quality control, also coming through. So it's time we move on to the questions as we saw them coming through, quite a lot of them. Perhaps one of the most common ones that was coming through, I'm trying to pull out here, it has been the $1 million question that everybody has been asking. It's around, do countries need repeat evaluation in order to adopt and roll out, or is verification just sufficient? If validation is required, at what stage is it required? I know, Gillian, you touched a little bit on that. I think we may need to start there.
Sure. So I think what we have to keep in mind is different tests will come to your countries with different levels of evidence. So as Owen alluded to, there are some companies that have yet to really work in your region, don't have a history of supplying a high quality test. I think in that context, you might want to consider testing that RDT and validating it before you roll it out. I think for some of the tests that have gone through our independent evaluations or where there's other independent data to verify their performance, then perhaps a smaller verification would be more suitable. And then I'll just reiterate sort of what the WHO recommendation stated or guidance stated, which is that if possible, as you're rolling out these tests, if there are certain contexts where you can do exploratory testing, it won't be available in every clinic where you might use the antigen RDTs, but at least for some, then perhaps you can get a sense in your own hands what the rates of false reactivity or missed results might be. So I think it's going to, it's not a straightforward answer of yes or no, but I think it's going to vary on what data is available to you on the performance as well as the quality of that test, and how familiar you are with the use of antigen RDTs in your context. Owen, I don't know if you'd like to add any more there.
No, and nothing really. I think it's just critical that as products are coming out, like we've seen, some have had performance data that are really based on a minimum number of samples, and having higher evidence and higher quality data to compare is going to be important. And obviously coming back to the work you all are doing and that WHO-EUL process to allow for the ease of comparison.
Great, thanks both. Moving on, I think around the same subject, there are quite a lot of questions around the comparisons, whether it's validation or verification. Questions from Adesola and then also Prof. Wendy. And Adesola was talking about when you're comparing the antigen test kits, I assume he's talking about comparing with PCR. He was talking about lowering the CT values to at least 25, increasing the sensitivity. Can this not exaggerate false positives? Along the same lines, Prof. Wendy asks, what is the reference material? What reference material works for these assays?
Great. So, I'll note that if you're using these antigen RDTs, you won't a priori know what the CT value of anyone is. So the sub-analysis that we did on different CT value groups was really just to give you a sense that when someone presents with higher viral load, there's a much higher likelihood that the antigen RDTs will be accurate and pick up those individuals. When it comes to false reactivity, because the tests that we evaluated generally had pretty good specificity, and by definition, if they were falsely positive on the antigen test, that means they were PCR negative, so there is no equivalent CT value, right? So I think it's just important to note that the sub-analysis we did, you're not going to be able to use that when you're rolling out the test, but it's more for you to understand the populations that are likely to be positive when you use the antigen RDTs. To Professor Stevens' question, there is currently, as far as I'm aware of, no commercially available standardized reference material for these assays. As Owen pointed out, one of the kits, the Abbott test that I mentioned, does include a positive and negative swab that can be used for each kit to verify performance. We're also aware that there are some labs that are producing reference protein antigen. Those aren't really available in any standardized fashion, but that can be used for QC. But I think it's a big gap right now, and will be something I'm guessing that WHO, ASLM, others are engaged in, is figuring out what can be an implementable and rapid solution to ensure the quality and monitor, post-market surveillance of the performance of these tests and user proficiency. I don't know, Anafi, if you're aware of any EQA or PT that could be done with the antigen test.
Yeah, thanks a lot, Gillian. I know a few are coming up now from our traditional providers, but as this is coming through, I think we may need to get more information coming through and share. So moving on, I just want to say thanks to Patrick Mateta here in the chat, just making sure that we make sure that these definitions are quite clear as we talk about validation and then as we talk about verification. And he says, I think that the test has validation results. If the test has validation results from the manufacturer, verification will be sufficient. He also wants to add that maybe recommended for verification test is something that where we have performance which is questionable. Now, moving forward, I think another key recurring question in the chat has been about algorithms. I think I saw quite a number of questions asking about algorithms, and specifically something coming like, have you tried a combination of tests and see how they've worked out?
I think it's a good question of, can we learn perhaps from HIV, where we know that if we do testing in series in low prevalence settings, then that can address the concern of false positivity, where you need to get 2 positive tests in series and confirm with a third depending on your prevalence setting. I don't know of any countries or contexts in which anyone is trying this with the COVID antigen RDTs. I think we need to better understand their performance and perhaps shared cross-reactivity. But then it is, I think it would be of interest to do testing in series. I don't know, Anafi or Owen, if you have more to add on that.
Thanks, Gillian. Owen, you have something to add on that?
Not specifically. I think something to consider is that there are even variable performance for the assays that are coming available. And so while some products may have quite high performance and maybe lower specificity, by contrast, other products may have slightly lower sensitivity, but significantly higher specificity. And we often see that trade-off in product development. And so I think if that is considered and having a stepwise algorithm is considered, maybe looking at some of those characteristics of different products and linking those together so that you can appropriately limit your false negatives and false positives.
Yeah, indeed.
And just from a an operational standpoint. Oh, sorry.
Great. No, thanks a lot, Owen. I agree.
From an operational.
Please go ahead. Please go ahead, Owen.
Sorry about that. From an operational standpoint, I wanted to say that the even in a stepwise fashion like that, typically you will still have a turnaround time and a overall cost that will be lower than what you saw with PCR already. So a lot of those advantages would still come into play, but obviously where possible, following the WHO guidance and seeing if a single test is appropriate, or linking with NAT if it's feasible for a subsequent test.
Thanks a lot. I think we still have quite a lot to learn, and the practical issues also learning from previous public health emergencies. So hopefully as we move, I think we get to learn more. Performance of the test will be key, and the intention. And this will also have, I think, bearings into what we are currently seeing now. I saw a question, I think it came privately, where somebody was asking, what does this mean when we want to screen people at the airports immediately as they are arriving? And the issues of algorithms will come into play as well. There was also a question earlier on from Mo Mungati, and I just wanted to clarify, particularly this one. I think it's the one which is listed by WHO, standard Q COVID-19 antigen. How does it compare with the other kits that are currently in use? He says he sees a 1.9% positivity in Germany, so he just wanted to be sure that positivity is not taken as poor performance, where all the 425 cases were confirmed positive by other means. Maybe Gillian.
Hi. So I think there were a lot of different points mentioned in that question. I think what I understood though, the setting in which there was very low prevalence in Germany for both the chorus as well as for the standard Q, we don't fault the test because we have low positivity. I think it's important to show data in the low positivity setting, but what you will see is actually in our hands, the sensitivity went down a bit and the specificity went up. The data where we only had 425 samples and a low positivity rate, I did make a note to not really take that sensitivity estimate very seriously because the confidence intervals are so wide, but rather we stopped our evaluation based on poor specificity for which we had over 400 samples. And so we had a tight confidence interval. And then I think there was a question on how the standard Q performs, because that is the test that was approved through the WHO EUL procedure. So the data that I showed you indicates that it does meet the performance specifications, and based on WHO's review, it met the quality standards as well. So I think you can expect it to perform well, but obviously each country will have slightly different performance, and as noted previously, if you can monitor the rollout by having some confirmatory testing, that will be quite beneficial.
Thanks a lot, Gillian. Owen, there's a question that came through. Is the product, is the WHO prioritization tool available online?
Yeah, it's not available yet. It's being finalized, and we're pulling in a lot of the data to be able to allow the tool to run automatically with the tests that are now being reviewed through WHO EUL. So once that is all put together, it will be out, but it should be very soon.
Okay, thanks a lot, Owen. We appreciate lots of questions that are in the chat, although we've just reached the hour, but very subtle and interesting direct question that is coming through from Samira. He or she says, finally, when can you really use RT-PCR and antigen RDTs? I think it summarizes, I think, all the discussions that we had already.
I'll take that from an operational standpoint, and Jillian, if you want to take that from a performance look. But I think if we go back to the WHO guidance itself, really the focus is around some of those key considerations of where can RT-PCR be provided, both efficient in a way to actually achieve clinical effectiveness, and how that can be defined is first off having a turnaround time, a rapid turnaround time that allows you to isolate those cases as quickly as possible, but also being able to appropriately scale testing, and based on different quantifications that countries have done, PCR in most settings has just not been able to meet the demand that is desired. And as I mentioned before, and I think Yenu had done a good presentation on, the testing yields really indicate that a lot more testing can be done. And so where RT-PCR really can focus is, first off, in those settings where it can provide a rapid result, but also using it within the set budget that's available, and understanding that being able to scale antigen tests outside of those settings. So these are outside of urban settings, but also even in urban settings where, let's say, inpatient, where a rapid result allows for that patient to be quickly isolated away from and put in a ward so other people are not infected within that same ward. I think in most cases you can look at antigen as a potential priority test, and look at RT-PCR as feasible for some of that confirmatory testing. So I think really you have to look at it in the context of your full quantification. And if you want to test 2 million people and that's how you'll stem your epidemic, can you do that with RT-PCR? Can you reduce your R0 under 1 with that and with the available budget? Probably not. And so, I think that product mix is where that has to come into consideration.
Awesome. Thanks a lot, Owen, for that nice summary as we try to close. Gillian, similarly, in a few seconds, any of the remarks as we close?
Yeah, I think as has been the case for almost everything related to COVID, we're having to move a lot faster than we'll ever have sufficient data for. So I think in making antigen RDTs available and providing guidance, WHO has provided some suggestions as to the settings in which we're probably most confident that the antigen RDTs can perform well and achieve, high sensitivity and relatively high specificity. But I think for each of you that are managing country programs, figuring out what the most important need for your program is to respond to this epidemic, and to be able to put in place the right confirmatory testing so you can feel confident with your testing will vary. And so if you have access to PCR and you can confirm the antigen testing, that's great. If you don't, then select a test that you can verify its initial performance, or where there's sufficient independent data showing sufficient performance, and then start monitoring it as you roll it out in the settings which are most critical to your country context. So, and stay tuned. I think as we all generate more data and share it with each other, it'll help inform the best strategies for rollout. Over to you, Anafi. Thank you.
Indeed, thanks a lot, Gillian. I think where we don't have data, I think this data from independent evaluation will be at least the first starting point for us to move on. So it has been a great session. I think we need to close now, and moving on. I think from what we are picking from here, I mean, the resources will be critical. I mean, we don't probably all have enough resources to be testing everybody whom we want to test. And hence, common questions have been coming through, particularly how do we do about this? How do we go about this? Owen has laid out practical consideration. From a scientific point of view, a common question around pooling of testing has been coming. Can we be able to test more people at the same time using a single test? And this is the subject of our next session, which is coming on the 1st of October. So stay tuned. We should be sending you the invite soon, and hopefully you'll be able to join us as we do so. On your screen now is for those that who want to document their participation in this session. On the screen is the code that you need to go to the ASLM Academy and be able to download your certificate and also watch previous sessions that we have done, particularly those that have happened in the past couple of days. This session will be available on the Academy site within a day or two. So if you don't find it immediately, please just wait a bit till we meet again. And thank you. Goodbye.
Thank you. Bye-bye.
Bye-bye.
Thank you.